Good afternoon to you. Thank you for joining the meeting. Unfortunately, I think there's some technical issues. Some people are having difficulty joining, and probably the chair as well. I don't know whether the host can do something. So colleagues, once again, thank you for joining. There's a technical problem. Many people have been locked out, including the chair. So please hold on if you can hear me. Otherwise, we'll start shortly. Can I check if you can hear me? Someone say yes.
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 Yes, we can hear you.
Yes, we can
Very
hear
clear
you.
and loud and very clear. We can hear you.
Okay, good, thank you. I don't know what we'll do, whether we'll continue without the chair, but I see some senior people
We
here.
can
In
hear you.
the next few minutes, if we don't solve the problem, we can start. Doctor, Okay, colleagues, let's start our discussion. Good afternoon once again. Let me ask the host to share the slides and we start. But as we start, I want to thank you for joining today's lecture. And we are going to concentrate on a very common problem of cough. And we want to concentrate on chronic cough, especially that cough that is unexplained. Edwin, can you share the slides, please? Or I share them from here? Okay, very good. So thank you, Edwin. If you can put in slideshow. Okay, so thank you. So we are going to concentrate on chronic cough. That is my name. And mainly, our discussion is going to concentrate on discussing what is needed in the clinic to deal with a patient with chronic cough. Next slide. So in this slide, we shall first of all look at cough in simple terms. Cough is simply the act of expelling air from the lungs. It usually happens suddenly, and in most cases, it creates a sound. We all know that cough is a very vital reflex that prevents aspiration and helps in airway clearance. So everyone has coughed and everyone knows what cough is. Maybe you can hide this. So cough can be classified into broadly 3 categories. The first category is what we call acute cough. And this is cough which lasts less than 3 weeks. We also have subacute cough, which is cough that lasts somewhere between 3 weeks and 8 weeks. And then we have chronic cough, which lasts more than 8 weeks. So that's how we try to classify cough in terms of time. Although we know cough as a simple symptom, which everyone has experienced, people are bothered about cough. And these are some of the common reasons why people are bothered about cough. And they seek medical attention. People, when they cough, they are bothered that probably this cough could be a sign of an underlying serious disease. Cough also can lead to vomiting, exhaustion, disturbance of sleep, as we see, cough which comes at night. It can also be a social embarrassment. It can cause difficult speaking on the phone. We have seen patients when they have cough, they can barely sustain a conversation. But we know it can lead to urinary incontinence. There are problems like rectal prolapse. It can be an annoyance to the family if someone is coughing and people want to rest. But also, as we know, in the last couple of years, cough became a sign of serious disease. Actually, during COVID, if you coughed somewhere in a mall or in a bank, everyone would turn around to see who is that is coughing. So therefore, that's why today we said, let's look at this symptom of cough. Next slide. So we'll simply recap the physiology of cough. I know this meeting today has been attended by people who are not medically trained, but we know that each cough to occur, there must be stimulation of what we call the cough reflex arc. So an arc presupposes something which goes and comes back. I hope people can understand that. That arc is taking information, but will come back with information in the same area. So to stimulate that arc, to take information somewhere, we'll show you where it takes it and where it picks it from. There must be activation of what we call cough receptors. Now, maybe to slow down a bit, the word receptor may sound difficult, but it is not actually difficult. Receptors in biology are molecules which are involved in transporting information, picking information and transporting it in form of signals. These molecules are either found in the cytoplasm, in the extracellular space, or on the cell surface. If you go back to that cell biology and look at a cell, we have the extracellular space, intracellular space, and the membrane. Now, those molecules are in those areas, and their work is to sense information, to receive, as the word receptor presupposes, and start a cascade of signaling that information. So in terms of cough, we have broadly two types of receptors. The first receptor is what we call mechanical cough receptors. These receptors are stimulated, and this is very, very important if we are going to understand cough. They can be stimulated by touch, by displacement, meaning that if someone, I will give an example, if someone tries to choke you, not to strangle you by the neck, that is a mechanical stimulation. It can cause cough. Okay, but also note that acid is a form of mechanical receptor. Someone would have thought that this is a chemical or activator of the receptor. Then we have the chemical cough receptors, which are stimulated by cold, by heat, and other chemical irritants. Now, where are these receptors found? Contrary to what we believe, these receptors are actually found in a number of tissues. In the epithelium of the upper and lower respiratory tract, that is the lining of the airway. In the pericardium, the covering of the heart, the esophagus, the diaphragm, and the stomach. So what that means actually, when someone is coughing, you need to look at all these areas. Could the problem be in these areas? And that's where we start to understand the physiology of cough. Next. Now, in this diagram, we show you the location of the receptors of cough. I've already mentioned those. As you can see, they are in the airway, they are in the trachea, they are in the pleura, they are in the stomach, they are in the esophagus, all these areas. So those receptors now, remember the stimulators of these receptors, they're either mechanical or chemical. When they are stimulated, someone said they can't.
We can see.
Okay, so maybe it's an individual problem. So, so those receptors there, they pick the signal. After picking this signal, take it through the vagus nerve. Now, this vagus nerve takes this information to the cough center. Now, this cough center is very important. It is found in the medulla, in what is called nucleus tractus solitarius. Now, don't mind about these words, but they are speaking something. One, what we know is a nucleus, it is tractus, and it is solitarius. It is found in the medulla. Now, once the information reaches the medulla, that is in the brain, three things will happen. The center, this solitarius center, will send information to the spinal cord, to the muscles of respiration, through the spinal nerves. That is the expiratory muscles, the pelvic muscles, and that's the between coughing and incontinence, the diaphragm, the trachea, the larynx, and all the other breathing apparatus through the spinal nerves, the phrenic nerve, and the vagus nerve. Okay? Now, once this information reaches there, a cough reflex is initiated. And remember what I told you, that this is an arc. So something starts from where the receptors are, in the trachea, in the diaphragm, information goes, reaches the nucleus solitarius, and then comes back to where the signal came from, and the cough is initiated. So this is how a cough is initiated. So therefore, when people are coughing, we need to look into these areas. The differential diagnosis can be got from this diagram. The one down is a bit complicated, don't bother about it, but just the one which is of boxes. So you can see anyone coughing, we don't care what has caused the cough. The problem is in one of those areas. And what could be the problem? It could be irritation caused by infection. It could be irritation caused by pollutants in the air or anything which is irritates. It could be a mass growing in that area causing pressure. It could be acid from the stomach passing through and leaking and reaching the esophagus, or stimulating those very cough centers in the stomach, because I told you there are cough receptors there, and the cough is initiated. Once we have this picture in the head, the rest, I can even stop here. I hope you are still hearing me. Next slide. So let's look at the epidemiology of chronic cough. How common is chronic cough? Chronic cough is actually not very common. And if you remember, that is cough which is lasting more than 8 weeks. According to studies done globally, we find that somewhere 10 to 5–10% of the adult population has chronic cough. Okay? Now, I try to look where are the studies of chronic cough in Uganda, and I'm going to show you that. But globally, what we know, that the cough is more common in females, okay? It peaks around the 5th to the 6th decades, mainly in the old people. That is chronic cough. When it comes to acute cough, this the demography, the age changes, because the children have more of the chronic cough. Now, when you look at data in Uganda, I came across this paper published in 1971 by P.G. Smith. Okay, someone wants me to repeat the cough, but we'll come back. Let's first finish. So in 1971, P.G. Smith went to, that time it was called the Lango sub-region. Of course, now there are many districts in there. And he surveyed 1,172 people in the community. So what he found that people who had a chronic cough were 4% of males and 4.2% of female. That is cough of greater than 4 weeks. That is subacute. For chronic cough, he found that actually chronic cough was higher in females at 9.8% and 6.5% of males when you took those ones above 50. Again, confirming that chronic cough is common in females, and cough per se, we can discuss that if we have time, but also in the elderly. In the small graphs you can see on the side, I'm sorry you may not be able to see this. I just put this here for illustration. In 2014, we conducted what is called a National TB Prevalence Survey, where we interviewed 40,000 people in this country, all over the country. And what did we find? We found that people who had a cough per se, okay, were 2,333, and as you can see, we found that people, those ones who had a chronic cough of more than 8 weeks were about 600. And as you can see in the small table below, when you get to these slides, the prevalence of cough in those ones who had chronic and no chronic cough, I mean of TB, because we're looking for TB, was almost the same. So what am I saying? The take-home message you have to take from here, that full chronic cough is not very common, okay? But it is a source of discomfort. It's around 5%. Next slide. So according to this map, this is a map from the Global Survey of Chronic Cough. You can see where it is red, it's greater than 20%, 15 to 20, 10 to 15, 5 to 10. You can already see, I hope you can see my cursor, that in this is North America, it's about greater than 20%. I think this is the Asia, the Northern Asia, it is also very high. But when you come to most developing countries, you can see that it is mainly gray. Gray meaning that no data. I hope you see that we need to do more work to know who has chronic cough. But you can see South Africa had a bit of data, and it was somewhere 5 to 10%. Okay, and then of course China has a lot. Of course, this map also is a mirror of the smoking rates and availability of data. We know there is a lot of smoking in Asia and China and Europe and then the Americas. But the important thing is that the data is not available. Probably we also have chronic cough. Next slide. So in this slide now we come to the actual business. With the cough arc and the receptors and all that in our heads, we now look at cough. Now, we know there are many causes of cough, but today we want to concentrate on that cough, as I'm going to say, which is unexplained, okay? Where you have done, we know TB causes cough, there is no TB. Asthma causes cough, there is no asthma. There is no COPD. There is no bronchitis. The chest X-ray is normal. You have done all the tests, everything is normal. What is causing this cough? Okay? So cough, therefore, can be looked at in 3 groups. Okay? I'll put these groups to facilitate understanding. The first group, someone has cough and there is no overt lung damage. There is no structural lung damage. For example, the X-ray is normal, everything is normal. What could be the problem? 1, it could be asthma. 2, I have put specifically this one here because it is going to form a lot of our discussion. Atypical asthma syndromes. I don't know whether you've heard about this word. It is coming up and we are now using it. These atypical asthma symptoms are people who have asthma, but you cannot touch it. Everything does not look like asthma. So there are 3 groups of patients here. What we call non-asthma eosinophilic bronchitis, cough variant asthma, and an atopic cough, basically an allergic cough. Second, could be COPD, could be GAD. This other one I have highlighted is the reason we are having this lecture. The post-infectious cough. Post-infectious cough, prolonged. We have seen, because respiratory infections have become very common of recent, influenza, RSV, SARS-CoV-2. We are seeing more people who initially had an acute upper respiratory infection. This infection goes away and they go on to cough for the next 3 to 4 months, and this becomes a burden. The other cause is what we call the upper airway cough syndrome. We used to call it postnasal drip. Okay? Then the other cause of chronic cough where you cannot see any lung damage are medications. Commonly, SE inhibitors, but also other medications. I recently quote this one in one of my patients. Calcium channel blockers, very common, your amlodipine. Biphosphonates are not so commonly used in Uganda. This is for bone disorders, but of course, people are increasingly using them. Middle-aged women also cause a chronic cough. So when you look at a lung which is normal and someone is coughing, please look into these things. The easy ones are cough in a patient with structural changes on chest X-ray or CT. Usually bronchiectasis, seen a mass, they have cancer, they have a foreign body, they have interstitial lung disease, they have a lung abscess, or they have positive lung disease. These ones, most of the times, are caught early. Okay? These ones are usually caught early, and when they refer them to us, they say, we are sending you lung cancer, we are sending you positivity. Then the last group, unexplained chronic cough. This group does not include A, does not include B. I hope people can follow me here. They don't have asthma. They don't have all these things. They don't have B, but they are coughing. We originally used to call it chronic idiopathic cough. This word idiopathic, we are removing it from most of the naming of diseases these days, because with technology we now know we cannot say we are idiopathic. Or we used to call it cough hypersensitivity syndrome. If we had been in a physical class, I would have stopped here to check if you are still with me. But since we are in the virtual class, I will just continue. But just to take a small break, think about those three broad groups of cough. And next time you see a patient, ask yourself, is this an A cough patient, B cough patient, or C cough patient? Next slide. Okay, thank you, Edrin. Make it big. That's good. So how do we approach? Now that we know that is cough, how do we approach it? How do we diagnose cough? So for this diagram here, do not bother so much about it, but it's to show you what I have gone through. For example, when you have a patient who has a chronic cough, take history. One, I hope people can see. We have put that one in red. Always someone who is coughing, look, red flags. Okay? Edwin, if you can go down, there is a box there which shows red flags. If someone comes you coughing, first check. Do they have hemoptysis? Are they smokers? Okay. Okay. Do they have shortness of breath? Do they have fever? Have they lost weight? Do they have edema? Do they have trouble swallowing or drinking? Are they vomiting? Okay. And do you have any imaging or respiratory exam findings? Please, if you have someone who has chronic cough, start from there. Take the history of red flags. The same way we teach in cardiology, if someone comes with chest pain, it doesn't matter, let them pain with their chest, but make sure it's not a cardiac attack. I mean a heart attack. Even here we are saying, let people cough, but they should not have these red flags. So once you have taken that history, take history of occupation, very important, travel, exposures, physical exam, and imaging. Okay? If a cause of cough has been found, the next thing to ask yourself, is it life-threatening? Okay? I hope people are still with me. And if it is not life-threatening, then you are good to continue. In the big box, I have already given you this one up there, the upper airway cough syndrome, okay? Secondary to sinusitis, asthma syndromes, the non-asthma eosinophilic syndromes, and the acid reflux syndromes, okay? So in other words, what is in this diagram here is to make your life easy, but in me, the way I approach cough, I put it in the 3 groups. One, you come with been coughing chronically, I will obtain a chest X-ray. Once I have put you in a group, I don't see anything abnormal on the X-ray, I know my possibilities. There are things which are abnormal on the X-ray, I decide what is abnormal in the X-ray. Is it a pneumonia? Is it bronchiectasis? Is it cancer? Is it a mass? Is it interstitial? If I don't see any of those, and you are not in A, you are not in B, then you have unexplained chronic cough, and I'm going to take you through this. Edwin, we can continue? Okay, I hope we are still together. So here, there are these 3 commonest cause of cough which disturbs people and they are referred. One, I'm going go through some of these special ones. Atypical asthma syndromes. These are asthma patients. They are not wheezing. It's not like they have an attack, but the underlying pathology is asthma. Number 1, cough variant asthma. Number 2, eosinophilic bronchitis, or what we call non-asthmatic eosinophilic bronchitis. I'm going to break this one down. And then number 3, atopic cough. Now, we will come back to this table, but these are the characteristics. You can actually see in cough variant asthma, do we have airway obstruction? The answer is no. Okay? So if you do your spirometry may be normal. Airway hyperresponsiveness, yes. Do they have sputum eosinophils or peripheral blood eosinophils? Yes. Do they have an allergy-like syndrome? Most of them you can't touch any allergy. Okay? Do they respond to steroids? Yes. Then for eosinophilic asthma, you can see all these things are not there. The only thing you find, they have high eosinophils in blood and sputum, and they respond to the steroids. Atopic cough, everything is not there, but they have increased eosinophils in their sputum or blood. They have allergies, and they respond to steroids. So what is the point? The point is, we need to start recognizing the contribution of these atypical asthma syndromes in patients who have unexplained chronic cough. And I will tell you, many patients who reach our table here at the Lung Institute, this is all we need to do. Just give them ICS and they are good to go. There is actually some patients who recently I gave treatment. He has given me a cow, but it is 400 kilometers away from here. So I think the money to bring the cow is more than what the value of the cow. But just to show you that after 30 years of cough, realizing the importance of these atypical syndromes made a difference. Next slide. We have these artifacts. I don't know where they are coming from. So now let's start these atypical asthma syndromes one by one. The first one is non-asthmatic eosinophilic bronchitis. Okay? So patients with this syndrome, they have atopy tendencies, they have elevated sputum eosinophils, but as you know, in our setting, we cannot do induced sputum eosinophils, but what we do, we use peripheral blood eosinophils. I see when patients come to the Lung Institute, we tell them, please go and do a CBC. They say, but why should I do a CBC? My problem is in the lungs. We are looking for these eosinophils. We know that peripheral blood eosinophils correlate very well with the ones in the airway, and we know eosinophils mediate a lot of airway inflammation. What are the other biomarkers we have for high eosinophils? Is our FeNO. This FeNO test, this is a fraction of exhaled nitric oxide, is available now in the country, and we can do it. And to my pulmonologists and fellows, you need to know that evaluation of patients with chronic cough is not enough, is not complete unless you've done FeNO and peripheral blood. If you came and look at 100 patients at MRI, despite all these things being available, you find only 20 have these biomarkers, but they are very important. These patients who have non-asthmatic eosinophilic bronchitis respond very well to inhaled corticosteroids. Actually, in many cases, we treat them as asthma. So I will quote for you this study here by Metiso. Okay, so this Metiso looked at 367 patients who had non-eosinophilic or non-asthmatic eosinophilic bronchitis. Someone is not hearing. I don't know whether it is their problem. Edwin, how is the sound? Because the internet is
we can hear you, Dr. Bruce.
Okay, thank you. So now, here, what point am I going to bring? That these people who cough like this, finally, some of them develop asthma. And you can see that in this study by Metiso, which I've told you, he followed 367 patients, 55% of them remained symptomatic, but their lung function didn't change. 32% recovered from their symptoms, and 13% finally developed overt asthma. So this emphasizes the point that we need to evaluate these patients very well and give them appropriate treatment, because some of them actually could go ahead to develop overt asthma. Next slide. Okay, this is the famous one, cough variant asthma. This one, our senior consultant used to teach it to us sometime back, Dr. Kutnoan. Cough variant asthma, very common and a nuisance. This cough variant asthma occurs in patients, or is a form of asthma, which is occult. Actually, they describe an occult form of asthma, whose only sign is a cough. Lung function is often normal. I've already told you that. A significant proportion of these patients, when followed, also further develop asthma. And this is another study. This one is by Matsumoto. For him, he had 42 patients. The other one had 367. He followed them for 4 years. What did he find? He actually found that 13 of these 42 people finally developed wheezing. 17 got cured, and he also found that early initiation of corticosteroids was useful and prevented development of overt asthma. Okay? Now, cough variant asthma particularly responds to leukotriene inhibitors. Next slide. For some reason. So this is a clinical PAL. If you find people who have cough variant asthma, and I will tell you, people will even think you're a magician. You ask them, this cough, does it come at 4 a.m., between 3 and 4 a.m.? They will say, doctor, as if you were there. How did you know? This cough always at 3, it wakes me up and I start coughing. During the day, it's not a problem. 3 a.m., 4 a.m., everyone is sleeping, I'm coughing. Then you will say, okay, Now I have got you. You have known that I went to medical school. Let's now start treatment. Then they will believe you. Because the patient must believe the doctor if they are going to be cured. Otherwise, they will throw away your medicine and take other things. So, just to know, in addition to inhaled corticosteroids, all the things we give for asthma, these patients particularly respond to leukotriene inhibitors. I will not go into the physiology of this, but that cough which comes at 3 a.m. is usually during the night you accumulate a bit of bradykinin and other things, and then they accumulate and then you start coughing. But just know that they respond very well. And in this study, of 14 patients with variant asthma, this gentleman here, I think he's a gentleman, Spectre, okay, randomized with, this was his study design, follow him very well. He got 14 patients and randomized them to receive montelukast or no montelukast, but he allowed a 7 to 10 day running period, okay, and a 4-week treatment period. So you see these are very innovative way of evaluating efficacy of treatment. But of course, if it is a life-threatening thing, I will not allow you to observe me for 7 days, then you give me treatment after 10 days. That may not be applicable to some diseases, but in some diseases, patient-owned control may be the best way to evaluate if no treatment is allowed. So in 7 to 10 days, he did give treatment, and after 10 days, he gave montelukast, okay? What did he found? He found that the mean percentage change from baseline in the cough frequency was 75.7% in the treated group compared to 20.7 for the placebo group. Meaning the people who he gave the treatment 75%, there was improvement compared to 20%. So montelukast is very available in most of our pharmacies. It's fair, affordable. Of course, I don't mean, the problem with the specialists, once we say something, everyone goes and starts giving montelukast. We find everyone tomorrow will go home with montelukast. But should you convince yourself that this is cough variant asthma, please add a leukotriene inhibitor on your inhaled corticosteroids, overlapped a little bit. Our practice here is, once we diagnose you, even if you're not very sick, we will overlap a little bit inhaled steroids with a bit of systemic steroid, 3 to 5 days, and then now you will see the response. Next slide. This one is now very common given this COVID is around. Post-infectious cough. So this is a cough which lasts more than 8 weeks after experiencing acute respiratory symptoms. The symptoms go away, the flu will go away, everything will go away, but the cough will stay. But we know the upper respiratory tract infection did not go to the lungs. I hope you can follow me. You do an X-ray, there is no structural damage of the lung. The infection didn't reach there. So what is happening? What is causing this cough? In most cases, this upper respiratory tract illness is an allergy of the upper airway, and you have what we call the upper airway respiratory syndrome. Remember the postnasal drip. In most cases, but in some cases, using what has been described as the one airway hypothesis, that inflammation in the upper airway, in most cases, is in the lower airway, only that we cannot see it. That inflammation continues. But what is happening with this, all this mucus and yellow sputum people are bringing post-infectious? Because the other bacterial infections, they come, pathogens, they come to take advantage of the weakened innate immune protections of the lung, the lower lung, will grow. So chlamydia will come in, strep pneumonia will come in, and other infections will come in. So in that case, the treatment of that cough is 1, control the inflammation. Number 2, probably treat for the secondary bacterial infection. Now, not everyone should be given an antibiotic. We have biomarkers of bacterial infection. 1, a raised abnormal CBC, white blood cell count. We have what we call procalcitonin. We have CRP. We have ESR. But I appreciate in most of the primary care facilities, these things are not there. And that's why we teach these clinical powers. Ask the patient, how did this cough start? You know, doctor, what I had this flu. It lasted 2 days. I thought it had gone. My nose had dried. Then I started coughing. What's the color of the spitter? It's purulent. Exclude all the other things. They are wheezing and everything. If there is nothing, then you may think that probably the secondary bacterial infection, and then you can add some more antibiotics. I have not mentioned it here. Staph aureus is very notorious for taking advantage of a flu-like infection to get ground into the lungs. As you know, Staph aureus is not good enough to grow in lungs. But after an infection, it can come there. This kind of cough is now very common in Kampala for reasons we cannot explain. Next slide. Now I come to this one. This is not for the faint-hearted. As I told you, the cough receptors are everywhere, in the ear canal, in the diaphragm, in the pericardium. So they are what we call the rare chronic causes, the rare causes of chronic cough. People who cannot swallow very well. People who have stroke, okay? People who have neurological disorders, especially even some of the ones which occur in childhood, like CP, they are prone to recurrent aspiration. Someone could be coughing, especially children, and people who are mentally retarded because they have a foreign body they aspirated and is lodged somewhere, causing irritation, but also acting as a nidus for infection. Anything which irritates that famous nerve, I showed it to you, the vagus nerve, it takes, but also brings back. You remember the cough app? Probably you do, if you join the alley. Anything which will irritate the vagus nerve, okay, will cause a cough. Disorders of the external auditory canal, disorders, anything affecting the larynx, the pharynx, the diaphragm, the pleura, the pericardium, the esophagus, any irritation around there. Because the receptors are there, the vagus nerve is there to pick the signal and take it to the cough center in the medulla. I really want to check who remembers this cough center. What is its name? Just type in the chat here as I take some water. No one. Let me see. I'm just taking a break, don't worry. Okay, if you remember the cough center, you tell me, but I can remind you, it doesn't matter whether you know it or not. Someone has remembered it. Nucleus tractus solitarius. Yes, thank you. Just to check if I have someone listening. So anyway, you've seen laryngeal neuropathy, chronic tonsillar enlargement. I think this is more, it is closer to the pediatricians. And then what is famously called the Arnold ear cough reflex. Okay? So these, once you have looked and looked, you always remember there are these rare things, but rare things are always rare, never bad about them. Next slide. Thank you. I see people are getting the center. It doesn't mean anything. What is important is to know that there is a center in the what? In the brain which participates in cough. Unexplained chronic cough. What are we saying? Despite everything that I've told you, a portion of patients will experience a cough that persists for more than 8 weeks and is unexplained despite a systematic assessment. And there is no response to empiric treatment. Remember the things I've told you. It is not TB, it is not asthma, it is not cancer. You go into the atypical asthma syndromes, cough variant asthma, give a trial of these treatments, work, the thing is not going, okay? These patients are considered to have unexplained chronic cough, UCC, which was originally called chronic idiopathic cough, CIC, or cough hypersensitivity syndrome. The prevalence of this cough is unknown. But in this study, this is what they found. 100 patients who had chronic cough and had been referred to a specialist hospital, that is the Royal Brompton Hospital in the UK, between 2000 and 2004. They found that 71% of these patients with unexplained chronic cough were female. The median age was 57. The median duration of symptoms was 48 months. That is, 48 months is about how many years? 4 years. But it could be up to 384 months. Can you imagine? How many years are those? Those are so many years. They found that unexplained chronic cough accounted for 42% of those patients. But they also found postnasal drip syndromes. This is actually another common cause of cough, which primary care people need to take serious. 22%. Gastroesophageal reflux, 16%. Asthma, 7%, and others. Patients with unexplained chronic cough were more likely to report an upper airway infection as the initial trigger. Remember what I told you? They were more likely to experience an upper airway to report as the initial trigger of their problems. That's a clinical part. The time the cough comes, how the cough started. Next slide. I will not go through this. This is the approach to treatment. I have given you my understanding on how to approach these patients. But when you receive the slides, please go through this algorithm. Next slide. How do we manage unexplained chronic cough? That cough, the last slide, all the other things are not there. Treatment of patients whose cough remains unexplained despite thorough assessment involves the following modalities. 1, empiric treatment with inhaled corticosteroids or ipratropium. I'm going to explain each of these. Non-pharmacological therapy, such as speech therapy, treatment with nerve blockers, because we've seen the excessive stimulation of nerves is probably behind unexplained chronic cough. With gabapentin, we know we have gabapentin here. We use it for neuropathies of peripheral neuropathy and other things. Low dose amitriptyline or other opiates like aminophylline. But in the worst case, you could give these people nebulized lidocaine, otherwise called lidocaine. There are many experimental therapies for treatment of unexplained cough. Now, down here, just to convince you that unexplained chronic cough is a serious subject, You see that paper from Chest, treatment of unexplained chronic cough, Chest guideline and expert panel report. This is a common thing. No, not common, not common. It's a serious medical condition. I will give you the link to that paper. If you are interested, you can read it further and say how we approach this unexplained chronic cough. Next slide. What are the empiric treatments? The empirical treatments for chronic cough. One, inhaled corticosteroid. And there, I have given you the evidence if you want. But I know, of course, for the primary care people, all you want is how to treat your patient. You may not doubt, but I'm sure there could be academics here who are doubting. Systemic inhaled corticosteroids are important for unexplained cough, and you can see that systematic review, which included 507 participants. If you look here at this small thing, we call this thing a forest plot in statistics. Here is benefit, no benefit. I mean, no benefit, benefit. This is the line of no benefit, okay, of nullity. You can see in this systematic review, this diamond is on the side of what? Of benefit, meaning that it is better to give these people an inhaled corticosteroid, even if you don't know what is causing the chronic cough. Thank you, Adrian, for blowing up. Let's go back. Okay. So the rest is more evidence. Ipratropium. Ipratropium is an anticholinergic. And you've seen, as you've seen from the physiology, some cough is hyperirritation of the airway and the cough receptors. And giving inhaled ipratropium is important in the treatment of unexplained chronic cough. We have it on the market and can be used. I have been informed the chair of the meeting has finally joined. Professor Hurst, you are welcome.
Thank you, Bruce. And I'm so sorry. I'd like to apologize to everybody for being late. It's entirely my fault. It's very nice to be with you here today.
You are welcome. I'm toward the end, so we will be starting from there. So gabapentin and the pregabalin. These are, like I've already explained, it's like some way of thinking that probably the cough is neuropathic and we want to deal with the central mechanism and block it. In some patients, these medications could help. But I have to say there are no clinical trials, and I've quoted none, on the use of these therapies. Opioids, morphine and codeine. These are important in suppressing the cough center. And as you know, I will show you, I will get some minutes to talk about cough syrups, because there are so many on the market. For the young doctor or nurse, you usually get lost, you wonder which one should I prescribe. There are not many components of those syrups. The rest is business. There are very few things. Some of them contain codeine, and the idea is trying to suppress the cough center. Now, suppression of the cough center with these modalities should only be reserved for patients where we cannot find a cause. Don't get an actively coughing TB patient and suppress the cough center. You are not doing any good. Someone has asthma, the treatment is to treat the asthma, not to suppress the cough center. I hope that is clear. Next slide. Every next slide. So, sorry. Yeah, this is one of the last important slides. The non-specific anti-cough agents, and this is the slide I was talking about, that although you will find 1 million cough syrups on the market, the active molecules are limited. The first one is, which we know, is dextromethorphan. This compound decreases the sensitivity of the cough receptors via that pathway and reduces the amount of cough. Okay? It is useful in patients with the chronic peripheral cough, which, whether due to an infection or a known mechanism, but you want to relieve the cough. That's the usual dose. I'm taking off these few minutes to talk about this because when you get that bottle, they will tell you this, I don't want to name the brand names, but this cough syrup has dextromethorphan, 5 mils, equivalent to so many milligrams. As a medical practitioner, I need to know this and look at the mixtures in this cough. The next compound are benzonates or benzonatate. This one is a peripheral acting antitussive agent that presume acts by anesthetizing the stretch receptors in the lungs and the pleura. And that's the usual dose. Dextromethorphan, methorphan or CAS acts centrally, benzonatate peripheral. There's something about dextromethorphan which I will talk about. We used to use the mixtures with this compound a lot in COVID because it has another mechanism of action through the sigma-1 receptors, through which it is believed to reduce cytokine storm. The next compound is guafencin. Guafencin helps with the cough by reducing the viscosity of airway mucus. Okay? And you can go on. We already mentioned codeine, which is also a common component of most cough syrups, which works to suppress the cough. There are a couple of others, but if you go through these bottles, you will actually find that you are playing around these things. Of course, the other common component are antihistamines that reduce the allergy. Last to talk about is the subject of macrolide antibiotics in patients with cough and airway disease. In COPD, clinical trials have already indicated that there could be benefit of low-dose azithromycin in the life of patients who have COPD. But in patients with chronic cough, these antibiotics, macrolide antibiotics, especially azithromycin, which has antiviral activity, anti-inflammatory activity, and it has three: antiviral, antibacterial, and anti-inflammatory. Given at appropriate doses, because of their effect to reduce neutrophils in the airway, it is believed that they could help. Apart from clinical trials in COPD, there is no proper clinical trials of macrolides and chronic cough. But in the clinic, we tend to hang on them now and then, and you see them as prescribing them. Okay, next slide, Evelyn. These are the key references. I have put them here. I have decided to put the links because in most cases, when we send people these PDFs and people cannot find, but here, these references, you just click on that link and you will get the reference. For example, I used up to date the ERS guidelines on the diagnosis and treatment of chronic cough in adults. There is a link. Classification of cough as a symptom in adults and management algorithm. There is that link. Inhaled corticosteroids, their use, the survey of cough, and then the one I told you, treatment of unexplained chronic cough, chest expert guideline panel, there is that link. Next slide. Now, in the last 1 minute, I want to give you 2 bonus slides. This week, I came across through Twitter this abstract. And of course, our IT department, Edwin, had already pointed me to this website for retrieving information. So anyway, the reason I'm trying to say is that in the modern practice of medicine, we need to find quicker ways of finding the information that we need where we are in the clinic. And these people have made this algorithm here called ChatGPT. It's like Google, but it's just a quicker way, and I think a new way. I will not say more efficient because it's new way of looking for information. And this paper, which has been published before review, has indicated that actually this algorithm, it's a language algorithm, based on probabilities and other things, was able to pass the US medical licensing exam. They just gave the exam to it and passed it. What does it mean? It means that it was able to retrieve the information needed to answer those questions. So this is the 21st century, maybe where we are going to be teaching medicine. I don't know. So let's go to the next slide. The last bonus slide. Okay, this one we will not see. When you get the slide, you say, so I tricked it, I asked it, I wanted it to tell me the causes of pulmonary hypertension. And it gave me the causes. Then I asked it, how can we treat pulmonary hypertension? It also gave me how to treat pulmonary hypertension. So I thought I need to bring this out. Of course, Google is available and other search engines, but I know most of our young people, they want user-friendly things. Maybe they could find this one useless. I mean, useful. Sorry, next. I think that was the last slide. I want to thank you so much for listening to me for all these hours, almost 1 hour. I now hand over to Professor Hurst.
Thank you, Bruce. Really nice presentation through the pathophysiology and epidemiology to some really practical things about treatment. And yes, the future is there too with AI and ChatGPT. So that was really great. Thank you. I'm going to open it to the floor. So this is your opportunity to ask questions. Maybe you have practical questions about how to approach somebody with chronic cough. Very, very common problem. So if you want to ask a question, you're welcome to put your hand up or to put the question in the chat. Just while I'm waiting for you to think about your questions and to put those there, I thought what struck me, Bruce, was actually how similar the approach is that you guys are taking to the way that we would work here in London as well, because I see lots of people with cough, and I think understanding whether there's an underlying lung disease is the first thing to do. And then you're left with quite a large group of people who seem to have normal investigations, so normal chest x-ray and normal lung function tests, and you're left thinking about these other causes like postnasal drip and asthma and reflux. But I guess one of the things that perhaps you see much more of than we do is cough in people who've been treated for tuberculosis in the past. And I wonder if you could perhaps talk a little bit more about that, because TB can clearly lead to permanent structural lung disease, and telling the difference between that and reactivation is difficult. What would your advice be to people on the call around post-tuberculous cough?
Okay, should I go for that one first?
Sure.
So, yeah, thank you, John. Yeah, post-TB lung disease is actually a very common cause of chronic cough here. It causes lung damage. And actually, in a small proportion of these patients, even the lung could have healed completely, but it leaves behind a hypersensitive airway that will lead to cough and others. Now, I gave a schema of 3 groups. Chronic cough with the radiological lung abnormality. Yeah. Without any radiological abnormality, and then unexplained chronic cough. Now, the post-TB, in most cases, at least you will see fibrosis, you will see lung destruction, you will see bully, you will see cavities, distortion of the architecture, shifting of the mediastinum. You could actually see masses if cancer is developing, and you can see pleural thickening. Once you see all those things and someone has given a history of TB treatment, the approach is repeat the TB test. Now, there is some caveat here which we need to pull out. The commonest test we are using now in Uganda, at least, is the gene expert. So people have recovered from TB. You do a gene expert, it shows you there is some DNA of TB. Then treatment is started. The patient completely. Actually, we have 2 patients now on the ward. I don't know whether my residents are here. two patients, they have been treated 3 times because of the positive gene expert. So we recommend that it's important to check after some time if a patient has no signs of that TB infection, to check if these TB organisms are still alive by doing a TB culture at the minimum to see if the organisms are still living. Thank you very much. I guess that after living may be more important than the atypical asthma syndromes, which I spent a lot of time on.
Perfect. So we have a few questions coming through. I have to say, Bruce, the overwhelming messages in the chat, I don't know if you can see them on your screen, are thanking you for what was clearly a presentation that everybody has really appreciated. So lots of really positive comments, and thank you to everybody who's put those positive comments in. In terms of a few specific questions, so someone's been asking about the percentage of lignocaine that you might use in nebulization. What would your recommendation be around that?
I would want, first of all, to encourage people that if people need nebulizations of lidocaine, please refer them to a specialist center, because you can have other problems. So I think that is the best advice I can give. Do not attempt to do lidocaine. Here we call it lidocaine nebulization in your facility. Please refer these patients for further evaluation, because you can imagine if you do this in someone who the unexplained cough is probably asthma or any other hypersensitive syndrome, you can actually cause a bronchospasm, and you could dance for some hours with this patient.
So something that would be used with care and with expert guidance. Absolutely. Yeah. Next question is around pediatrics. So not something I know a lot about. I'm an adult physician, but Bruce, I wondered if you have any comments about cough in pediatric populations.
Yeah, I put in my title, I added adults.
I would have done the same thing. So I mean, I guess clearly some causes can affect kids as well as adults, but there may be different things in kids as well. So that's perhaps the topic of a different presentation on a different day, I guess. One of the things that's been occupying everybody, be that here in London or for colleagues over in Uganda recently, is COVID, and I wonder what your experience has been with post-COVID cough, Bruce. So are you seeing lots of people with ongoing respiratory symptoms who've recovered from COVID, and is cough a prominent thing for them too?
Actually, John, that is one of the triggers of me giving this talk. There are people who probably had COVID and they didn't know. Mm-hmm. There are those ones who are diagnosed, but for some reason we are seeing increasing number of people who have these stubborn coughs. Now, cough as a post-COVID syndrome can occur because of many mechanisms. One of them is lung fibrosis, which comes as part of the acute interstitial inflammation of COVID. This is actually the commonest, where these people have lung fibrosis, they have heart failure comes in, they have dyspnea, and they have overt lung disease, lung fibrosis. That is common. But we also have these groups of patients who are just coughing. Mm-hmm. X-ray is normal. They don't know whether they are diagnosed with COVID. Lung function is normal. And for some reason, in a series of about 7 patients, all of them have fairly responded to the treatment I described. Inhaled corticosteroids overlapped a little bit with systemic steroids and other anti-allergy and bronchodilators, including montelukast.
Yeah, I think that would fit with what we're seeing here as well. So we're certainly seeing a good proportion of people with cough, which is an ongoing problem after they've recovered from COVID. Lots of questions coming through now, so we're not going to let you off the hook quite yet. One of them is about positional cough and cough that is worse in people lying down. I don't know what you think about that. I guess I'm kind of thinking about gastroesophageal reflux or those kind of things. Is what kind of things might run through your head in that scenario? If there's a clearly positional element of cough. Yeah,
reflux could be one of those. But in those patients, please make sure there is no component of heart failure that has to be excluded. But it depends on what lying down means. Like I explained, most of these atypical asthma syndromes have a cough that comes in the middle of the night after people have rested a bit. It's not heart failure, it's the whole pathophysiology of airway inflammation. So there's that group. Specifically during the day when they are lying down for a few minutes, they will not cough. But should they lie down in the middle of the night, they will start coughing. But it would be important to exclude heart failure in those patients.
Yeah, definitely. I would agree with that. Picking the questions a little bit at random. So, Joseph, thank you for your question about combination treatment. So you're given us a sort of menu of different medicines that you might want to try. What would your view about combining those be if one isn't enough? Do you start one and then stop, or do you ever consider combination treatment? And that was actually specifically that was in relation to leukotriene and muscarinic antagonists.
I think if I'm in primary care, I would recommend people start with the single treatments, such that you don't put all these things on these patients. But when you sit where we sit here in the referral centers, most of these patients have gone through all these things that you are most of the times tempted to combine. Specifically, I saw someone leukotriene and anticholinergic agents. Yes, I think that could be a good choice if you have access to ipratropium. But I know up country it is not very available. But the good thing, Montelukast is available up country.
Okay, so next one is with regard to investigations, and I guess sort of the more specialist investigations, and in particular CT scans. So what kind of people are you thinking are really going to benefit for a CT scan? When should people be thinking about referral up to a bigger center for that?
Okay, the use of a CT scan in our environment, CT scan is very expensive. Maybe to put it in some perspective for you, John, it's about $150. And that's a lot of money for most Ugandans. So what we are recommending approach to imaging in people with lung disease is one, please do a clinic exam. Second, do a chest X-ray. If both of those are normal and someone continues to have symptoms, probably now you need to start thinking of a CT scan. The chest X-ray actually will repeat most abnormalities that cause symptoms apart from interstitial lung disease, from my experience. So, we usually do an X-ray, a CT scan after we have gone through a good clinic exam and a chest X-ray. And of course, the laboratory tests. For example, if you are coughing and you have all these other problems, and I do a gene expert 2 hours and it's positive, it would be good to have your X-ray and CT scan, but I could just start you on TB treatment and you'll be okay.
Okay, next question is, we're moving around a bit, so I'm putting you to the test, Bruce. Thank you for being so agile and answering these questions. The next one's epidemiology. So why are women more often affected by chronic cough than men, do you think? That's a sort of on the ground observation from Agnes here, but I think that's probably true, right?
Yeah, I think I've seen the picture. I always don't want to spend a lot of time on these gender things, but it looks like the cough reflex, it has a lower threshold in women, and therefore they will biologically develop cough more. Given the same level of irritation, women will cough faster. There are no empirical studies to that, but that's what we think happens. But also we need to know that there is the issue of health-seeking behavior. Women will consult more for their problems.
And I suppose there are differences in the prevalence of some of the lung diseases like asthma and COPD. So that also may drive, some of that. Okay, the next question is about cough in the context of a pleural effusion. How would that, actually it says massive pleural effusion here. So if you see a massive pleural effusion, somebody coughing, is that changing your differential diagnosis, or what are you thinking more commonly in that scenario?
Yeah, if someone has a massive pleural effusion, we need to deal with that effusion and evaluate what has caused the effusion that we are seeing. The causes of pleural effusion are many, but in our setting, we have a simple algorithm, the one we give to our interns when we commission them. If someone is under 45 years and they have an effusion, and it is exudative and it is lymphocytic, that's treat for TB. Probably 80% correct. If they are above 45, elderly, they have a lymphocytic exudative effusion, you could treat for TB, but also start to look for malignancy. And of course, if the effusion is transdative, look for things which cause transdative effusion, heart failure, liver, kidney, and other things. So, but the other one is really the rule of the thumb that you can use to start treatment as you look for other things.
Yeah, and likely to find a specific diagnosis, I think, in that scenario. There's an interesting question here. Are there any coughs that we shouldn't suppress? Are there any time where you sort of want a person to keep coughing, I suppose, to phrase it like that?
Very good question. I think any cough that you are not sure what is causing, don't over suppress it. It's the same thing they used to tell us, the surgeons. I saw some surgeons here. Someone comes with that acute abdomen, before you know what is causing it, don't give a painkiller because they may go and sleep and die with their thing. So even these coughs, we want to suppress them when we have an idea what is happening. But of course, there are some coughs which are so irritating that you are tempted to suppress it immediately as you look.
So there's, I mean, I think it's probably one of those things that appears in medical textbooks, and so is more common than you might think. But there's an old syndrome called Lady Windermere syndrome, which was where people.
Oh, looks like someone has muted you, John.
Classically, so there's a syndrome in the textbooks called Lady Windermere syndrome, and the idea here was that this was an older person, classically a female, who had bronchiectasis and who tried to suppress her cough, and that's associated with non-tuberculous mycobacteria infection. So whether that stands up to modern evidence-based medicine or not, I don't know, but it's clearly that there might be consequences of suppressing the cough in some scenarios. So that's a really great question. The next question is about psychogenic cough or centrally induced cough. Is that something that should be on the list somewhere as well, do you think?
Also again, very rare diagnosis of bleeding exclusion. As I showed you, the cough actually has input from the cortical component. I skipped that part. The cortex comes in. Whether people can manipulate whether they cough or not, it is possible because there is input. Although it's a reflex, on top of the act, there is input from the cortical, what we used to call supratentorial part, coming down. So it's like psychogenic cough could occur, but very rare. I have seen some epidemiologists saying it is also again very common in young girls, but you know those are not in clinical data really.
Okay. Next question from Ismail Sule is around azithromycin and macrolides more generally, and he's talking about the rationale for that. And I suppose we tend to think of macrolides for their antibiotic use, but they've also supposedly got these anti-inflammatory properties, and maybe they're prokinetic as well. So there's a few mechanisms, I guess, that they might work for cough, although you presented the data that would suggest that outside the context of COPD, so they're not so good. But what do you are these anti-inflammatory mechanisms, these prokinetic mechanisms, are these something you go with, Bruce, or are you thinking it's mostly for an antibiotic effect when we're using it in COPD?
I think we can limit to COPD. Of course, John, here where we are seated, there is an epidemic of antibiotic use. Everyone is going out with the following: augmentin, azithromycin, and an antihistamine, even if you have coughed and sneezed for 1 hour. So we are tending towards really discouraging people from using antibiotics. only in those special circumstances that I described. We know we have a paper in New England Journal of Medicine on macrolides and COPD. We know because of the mechanisms that probably in this inflammatory unexplained cough, there could be a benefit. Yes, you can use, but people who only have acute respiratory symptoms, we will discourage giving an antibiotic, including macrolides.
So coming towards the end of the questions now, one that we've not touched on takes us back to TB. And this is a question where someone has chronic cough and you've tried absolutely everything you can. You've looked very hard for a blind diagnosis. You've done TB tests, those TB tests are negative. Would you ever consider empiric treatment for TB in that situation? So chronic cough, test negative, but no other diagnosis.
Yeah, that's actually a very, very good question. Just to give the statistics, at present, probably nationally about 30 to 40% of TB patients are clinically diagnosed. And we are working to reduce that proportion. When I was a medical student and a resident, it used to be the other way around. Uganda was always highlighted as a country where most TB is bacteriological confirmed, up to 80%. And we had been told that probably we are missing a lot of TB because we can't reach everyone with a TB test. So, but now we have gone overboard. We have too many clinically diagnosed TB. And I'm happy that it really came out. I did touch it because it's a topic of its own. However, people who have negative TB tests and they have a normal chest X-ray or normal radiology, I would just follow them without empirical treatment. But there are people, they have negative TB tests, but they have a cavity. They have a mediastinal lymph node. They have classical TB tests, symptoms. They have had contact with someone who has TB, a family member. Okay, the HIV positive, probably those ones should be treated clinically for TB and observe if they are going to improve.
Thank you, Bruce.
But John, I also appreciate that people on this call, many of them may have no access to a chest X-ray.
Yeah,
so all they have is their patient and probably TB test. You can try and see if your patient improves. In 2 to 3 weeks, you are happy. If they are not improving, send them up for referral.
Yeah, that's right. People working in very different environments. Next question is about the mechanism of cough with ACE inhibitors, which, if my memory serves me right, is reduced breakdown of bradykinin and COX-2 inhibition, I think. But I'm asking neurons to fire, which haven't fired for a little while. Does that sound right, Bruce?
Yeah, that's actually what is believed to be the mechanism. Because you are inhibiting one arm of that pathway, and then the other one accumulates, and then people start coughing.
Okay, some speculation around the increased prevalence of chronic cough in women, and perhaps that might relating to hormonal changes around the menopause. So that's a comment really, rather than a question. And then there's a question about post-radiotherapy side effects and whether radiotherapy in the lung, but also radiotherapy affecting the vagus nerve is a comment here. So I wonder what we know about radiotherapy effects on cough.
Radiotherapy actually causes the pneumonitis. So you will get cough. And that pneumonitis can get secondary bacterial infection and you will still have cough. So you still need to go back to evaluating the patient to see, is it just a pneumonitis? Has the infection coming? This is common, especially in breast cancer patients who have gone radiotherapy. We've got a couple of those referrals coming to us. I hope I'm not getting disconnected. think our chair got disconnected. Let me make sure it's not me. Can you hear me?
We can, I
You're
can
loud
hear
and
you.
clear.
Yes, we can hear you, Professor.
I think it is the chair who got disconnected. Let's wait for him to come back. But we have a substitute chair, if he's still here. Oh yes, the poll question. What do we have in there?
Yeah, we can hear you.
Please respond to the poll. Edwin will show us what we have got so far. Oh, we have very good response.
We have about 372 responses already.
Ah, very good.
Yeah.
And what are the scores?
So 44% had seen about between 1 to 4 patients with chronic cough. The second group had seen more than 9, that's about 28%. Then 18% had seen 5 to 9, and then 10% had not seen any patient with chronic cough, but majority had seen about 1 to 4.
Wonderful. Can you publish that on our media? MRI media. So
Yeah.
I think, Wiz, can you take over and we conclude the meeting as the professor comes back? Or Rebecca or someone?
Yeah, I'd request maybe Dr. Rebecca to take over. I'm just concluding my clinic here.
Okay.
Okay,
Or
so
anyone? Okay. Okay. Okay.
yes, I think we are continuing with our questions. It looks like we had answered most of the questions, and we are almost a few minutes away from the end of the presentation. Unless somebody has a burning question which they can raise up their hands and ask, otherwise would maybe conclude. Yes, Professor is here.
Gosh, as you may be aware, there are some global problems today with Teams and Outlook, which causes everything to crash every time. I'm really sorry about that. I can't see any of the remaining questions. So if you have not had a chance to ask your question yet, feel free to put that into the chat. So I can see a couple of hands have gone up. So maybe Suleiman, if we come to you first, and then we'll go to Ojok afterwards.
Yeah. Thank you for the presentation. Thank you, Dr. Bruce. Thank you, everyone. I don't know if you can hear me.
Yes, please help me consent that patient.
Hello?
Help me consent that patient.
Go ahead, Suleiman.
Yes, these days there is a lot of throat clearing in the community. If you can hear people do that. Is it a sign of cough? Is it a sign of chronic cough? Is there something we are not noticing? There is a lot of what I would describe as dry cough in a community. Can I have a response to that, if possible?
Thank you for your question. Bruce, what do you think?
I think this is part of the upper airway irritation syndrome. What is sparking that off? Of course, we need to think. The usual seasonal could be respiratory infections, air pollutants, and of course, background allergy. But I think respiratory infections could be sparking this off. Those clearings usually could be also associated with the formerly the postnasal drip and the one airway thing which I told you, and inflammation even other parts of the respiratory systems. I think remedies which reduce sensitivity, I talked about those a little bit. So when you go to the pharmacies, look for those ones which have the compounds I told you reduce sensitivity, probably those patients could benefit from that.
Thank you, Bruce. And to Ojok next. You're on mute if you're trying to speak.
Yes.
Hello.
Yes,
Hello.
Professor.
Go ahead.
Professor, I mean, yeah, thank you so much, Professor Bruce, for all this informative, really information. Yeah, I was also following up with that clearing of the throat. At times, I personally also have it. But then I don't know how one would explain it, maybe when you took like cold water as opposed to maybe also hot water. So, I mean, is there anything associated with that? Because at times I have it, maybe if you took very cold water and then you find the throats like itchy, and then you're having that. I don't know how to explain it that way. Thank you.
That's a difficult one. Already I said that cold is one of the things which activate the chemical cough receptors, but here there's no coughing, it's only clearing. So meaning that increases irritation. We already know that actually allergies are the release of histamine and other allergic mediators are also related to temperature. And I don't know, Joe, if you have traveled on a border. You see in the morning, if you go to the border, especially if you are the one riding it, you could start sneezing. The whole thing is what we call the air nose velocity. When you are breathing air at a very good speed, your air has a way of warming it to bring it to a good temperature. If it starts moving so fast, then the cold may come in and stimulate a cough or a reflex. But particularly the itching is another mechanism which I can't explain very well. Probably John or someone else could come in.
I don't think I've got a lot to add to that one. I'm just sort of reflecting on, you know, the interventions that we have to treat respiratory symptoms, and it's notable that we have effective bronchodilators for breathlessness and wheeze, and that we've got at least in terms of eosinophilic type of inflammation in asthma, we have inhaled corticosteroids which can control the inflammation. And yet we're really missing things, I think, in our therapeutic armamentarium to treat cough. It's such a common symptom. And yet our options here, as you've heard, are limited in the sense of the evidence base. And so there's a very broad array of things, as you've heard Bruce describe. There's been quite a lot of research recently going into cough. I'm thinking about receptors like TRPV1. So that's the capsaicin receptor. So when you have a chili and you cough. So there's quite a lot known about those pathways now and drug development going on. So it may well be that over the next 5-10 years, we see new treatments coming through for cough. But at the moment, the approach that you've heard from Bruce, so trying to find a diagnosis and treating the underlying diagnosis before being left with more difficult to treat chronic cough, I think is absolutely the right one. But who knows what conversations we'll be having in 5-10 years time. There's a lot of really exciting science going on, certainly. Okay, we're coming to the last 5 minutes or so. So this is your last chance to ask Bruce any questions.
Hello.
Hello.
This is Dr. Jock Dennis. I have one question for you and for Professor.
Go ahead.
We have seen that we usually use TB LAM for diagnosis of TB in patients who are bedridden or those ones who have advanced disease. Why is it that we don't use them in other diseases that may also increase the possibility of someone having TB, like malnutrition, especially in children who are coughing for long? Why is it that we don't use in those children? We are encouraged only to use in HIV infected. Thank you.
Thanks for your question, Bruce.
Yeah, the urine TB LAM is based on have the principle that when TB is in the body of some TB will die, and something from their membrane called lipoarabinomanone, that is LAM, is accesses the blood system and is filtered in the kidney. That's the principal joke. So we actually found that it did not work very well in people who are not HIV positive or who have no weak immune system. Because in those people, it is rare for TB to disseminate and become systemic. So, and we have studies which showed the test was not useful in those people. But in the HIV people who have advanced disease, the chance that TB is disseminated is very high, and therefore we can easily catch this LAM in the urine and use it for diagnosis. Now, the tricky part of your question is, there are other immunosuppressive things like severe malnutrition, people on cancer drugs. I think these studies, we need to do them and evaluate and see the utility of the test. Here, I'm not talking about the accuracy of the test, the utility of the test. Putting things together, is there a value in offering a LAM test to HIV negative people? We found there is no value, but these studies, you and me will have to do them in that group of people. Probably it is useful. Now, let me tell you, even if I'm walking here and coughing and I'm HIV negative and I'm what? Should my LAM be positive? With me, you get a joke what I'm saying. What we are saying, we are not offering it for that population because most of them will be negative and will be wasting time. So it's beyond accuracy, it is the whole thing, including the utility of the test and health economics. I hope I have tried to answer the question.
You have answered. Thank you, Professor.
And we've got time for one more. So there's a clinical history in the chat, Bruce. I'll read that to you. So it talks about a 65-year-old female patient, and it says that the person has had a dry cough for 2 months, breathlessness, which is worse on lying flat. There are B symptoms there, no cardiac diagnosis. And on physical examination, tachypnea, so high respiratory rate 38, and there's reduced air entry at the right base, no wheeze, no crackles, blood pressure is 98 on 68, so very specific vignette there. And the question is, can this be chronic cough? Well, I don't know. There sounds to be more to me going on there than just chronic cough, Bruce.
I agree. The person is 65 years, has what sounds like orthopnea, has a cardiac diagnosis. Did I hear that?
No cardiac diagnosis. So I guess with that reduced air entry at the right lower lung, you could be thinking pleural effusion or consolidation. I guess there's a differential diagnosis to that. I suppose the important point to mention, of course, is that people with chronic cough in the background can still get acute illnesses on top. Just because you've got a chronic cough doesn't stop you from getting pneumonia on top of that. And if that chronic cough was part of an underlying lung disease. So I suppose the answer to the question then, from my point of view anyway, interested in others, my point of view, yes, this could be a chronic cough because she's had cough for months and months and months. But there's something else going on as well, and it's probably there's something else which is more urgent to treat right now.
Yeah, thank you, John. I think that patient should be evaluated.
And there's some more information coming through in the chat in relation to her. So people may want to have a look at that a bit later on. We are right at the end of the time. Bruce, fantastic presentation as always, really clear advice, but backed up by great science and epidemiology and expertly handled questions which were flying all over the place. So thank you for the presentation and the questions and lots of real appreciation from people in the chat. And I also want to thank everybody else as well for the great engagement. So thank you for being with us today, and also thank you for all your questions. I'm sorry we didn't get around to quite all of them, but hopefully most of you got away with something that you wanted to answer. So it's my pleasure to close this particular session, and best wishes to you all from here in London and to wherever you are today. So goodbye.
Thank you.
Thank you. Goodbye.
Bye.
Can we get the presentation or the link?
Thank you. Thank you very much.
Bye.
Thanks so much, Prof.
Thank you so much.
Thank you so much.
Thank you so much for the.
Thank you. It's been wonderful. Thank you so much.
Apoyo Matek. Apoyo Matek.
Thank you very much. Thank you.
Thank you.